Thank you very much for the invitation. So let's go right into it. I think this clicker has a prostate issue. Okay. Okay, so I'm going to focus on two questions. So the first question is, okay, someone or I did a DEXA scan on my patient, and now I have a bone mineral density Z-score, which is minus 2.2 in the lumbar spine, but never had a history of fractures. What do I do? And the second is, my patient with IBD has a 25 OHD vitamin D level of 12, which is low. What do I do? Sorry about the hesitation of the clicker. Point it down? Okay, thank you. All right, so I don't have to persuade you as pediatric gastroenterologists and people familiar with the field that IBD, especially Crohn's disease, can produce growth stunting. And there's good studies ongoing to resolve the mechanisms, including those of Dr. Neera Gupta, who's in the audience. So the good news is that we can now effect change in the growth pattern of patients, and this did not used to be the case. So we know that exclusive enteral nutrition and biologics such as anti-TNF alpha inhibitors can in fact increase the growth Z-scores as seen in this graph in this patient who presented with internally penetrating Crohn's disease. Intra-abdominal abscess was resolved and then was put on adalimumab, showing very nice growth. So we also know that the skeleton in patients with inflammatory bowel disease, especially in Crohn's disease, is configured abnormally in terms of bone geometry. So the bones are shorter, the cortex of the bones is more dense, and that, by the way, is not good news, because what it means is that the bones are more brittle. Also, the epiphyses of the bone show decreased bone mineral density. Now, an engineer looking at the material properties of this bone would predict that these bones are more prone to fracture, but the studies that would be required in order to demonstrate this effect in IBD would need to enroll thousands of patients and have not been done. And in adolescents who have a baseline fracture rate that is high anyway, a difference with adolescents with IBD will be hard to demonstrate. But nonetheless, just looking at the material properties of the bone, these bones should be more fragile. Now, the disease also has an effect that is often unappreciated, and that is of profound muscle mass loss, or cachexia. Now, the pull of muscle, striated muscle on the bone, is very important for bone development. And this is shown in space, for example, where astronauts can lose a lot of bone mass because of the lack of pull of gravity and their weight. So we don't know exactly why this happens in IBD. Dr. Palma-Doder, who is also in the audience, has started to look at this problem and has preliminary observations about the effect of experimental IBD on bone, on muscle stem cells. So it may be that this initial inflammatory hit is difficult to overcome. So going back to the questions, so we have now a patient who has a negative Z-score of minus 2.2 in the lumbar spine, and what this means is that the bone mineral density relative to normal children of the same age and sex is 2 standard deviations below. So it's important to know what this test entails. So this is really an X-ray of the bone that is done with 2 different beams of X-ray energy. These are attenuated differentially by soft tissue and bone. So they traverse the patient, and what you get is a film. Now, it's important to know that in individuals who are bigger, their bones are going to look more dense by this test, simply by virtue of the size of the bone, even if the bone itself has the same material density. So this is an issue to consider in interpreting data of bone density in patients with IBD who can be short. So, size matters. Right, Dr. Kim? Okay. Settle down. So, you may adjust for height Z-score in case a patient exhibits growth delay, and this is very helpful. And Dr. Babette Zemmel from the Children's Hospital of Philadelphia has published equations on how to correct this in the proper way. So in the patient that we referred to before, if the patient has active disease, the treatment for their low bone mineral density is nutrition and disease control and not a bone active agent. This changes if the patient has had fractures, especially fractures of the lumbar spine, which are subject to great remodeling in a positive way with bone active agents. This always should be done with an endocrinologist who knows about these agents. So there is hope. These are data again from CHOP, and showing on the right side of the slide that the trabecular bone density as well as the cortical bone density can improve over time if the disease is under good control. So what are the take-home points in this part of the talk? Of course, IBD can impair linear growth and skeletal health. It also affects muscle health, and it can produce cachexia. Effective IBD therapy can overcome to a great degree some of these changes, as well as linear growth. However, do not forget that patients with IBD may also have primary bone disease unrelated to their IBD. And therefore, if you have a patient that fractures, think of referring to an endocrinologist. Now, for the second question, so our patients typically don't like to eat vitamin D-rich foods like oily fish and things like that, and as a result, they may become vitamin D deficient, and also ourselves. I bet that in this room, a lot of us are vitamin D deficient. So, why is vitamin D important in IBD? So there are several studies showing that there is association with disease risk as well as with clinical outcomes. So it almost appears like the world now revolves around vitamin D. So vitamin D deficiency is common. It can antecede the onset of Crohn's disease by years. We know that vitamin D has immune effects on both the innate and adaptive arms of the immune system. We know that in experimental models, vitamin D deficiency or inability to respond to vitamin D results in more severe experimental colitis. And in mice that are treated with vitamin D is the reverse. We know that adequate vitamin D levels are associated with decreased risk of surgery, cancer, C. difficile, and improve outcomes, including quality of life. So we shall conclude that everybody in the world should be on high-dose vitamin D, correct? No, right? So we don't have a trial, actually a clinical trial, that has shown this effect. So until that is published, I urge caution. And part of it is because attaining a good vitamin D level depends on what we define by good, and also it is difficult to do. So this is a trial of vitamin D in normal, regular, healthy adolescents in the UK. And what you see here is the effect of dose on the serum 25-OH vitamin D. So the 30 micrograms per day shown there is equivalent to 1,200 units a day. And that was barely sufficient to achieve a level of 20 nanograms per mil in healthy adolescents. This will not be a surprise to you who have treated patients with vitamin D and found it difficult to increase their levels. Now, the good news is that in IBD, pediatric IBD, we have data to guide us as to how to do this properly. And the data come from Helen Papa and colleagues while she was at Children's in Boston. So this is a clinical trial where she compared different doses of vitamin D in the treatment of vitamin D deficiency in patients with IBD. And the bottom line here is that oral doses of 2,000 units a day of vitamin D3 or 50,000 units a week of vitamin D2 were able to raise the vitamin D level to the target level that they had of 32 nanograms per deciliter. Now, in order to maintain this level, again, you need high doses of vitamin D, at least in Boston, where the sun doesn't shine for 6 months a year, because it's high latitude, right? So it's very difficult to maintain this level. So what the implications are for that as far as outcomes in pediatric IBD are not yet known. Dr. Kim threatened me to pull me down from the podium, and that exceeded my time, so I thank you very much.